Welcome to Voices from the Field, the NAMA Next Gen podcast. I'm your host, Neil Nakkash. As conversations about healthcare access and affordability continue to shape our understanding of health in the U.S., few researchers have done more to study how health policy affects people's lives than Dr. John Ayanian. In this episode, I speak with him about the intersection of medicine and public policy, what we've learned from expanding Medicaid, and why health insurance alone is not enough to improve population health outcomes. Dr. Ayanian is the director of the Institute for Healthcare Policy and Innovation at the University of Michigan and the Alice Hamilton Distinguished University Professor of Medicine and Healthcare Policy. A practicing primary care physician, he has spent decades studying healthcare access, quality, and disparities with a particular focus on how public policies shape health and well-being. He also led the long-term evaluation of the Healthy Michigan Plan, which is one of the U.S.'s most closely watched studies of Medicaid expansion and its effects on patients' health, financial security, and quality of life. We're just so honored to have one of the nation's leading voices in healthcare policy research with us today. So here's my conversation with Dr. John Ayanian.
Thank you so much for joining us, Dr. Ayanian.
My pleasure to be with you.
So I just wanted to start us off by asking us about what really drew you to this intersection of clinical medicine, health policy, because you're someone who's trained in medicine, public policy, health services research, and especially at a time when those fields were often more siloed or less integrated than they are today.
So when I was a college student and a pre-med student, I knew I was interested in becoming a doctor, but I was also interested in the larger forces affecting how healthcare is delivered, how doctors interact with patients. I was actually a history major and political science major in college as an undergrad at Duke. And so when I was thinking about going on to medical school, I wanted to think about ways that I could combine a career taking care of patients as individuals, but also try to make a difference in terms of how healthcare is delivered in the larger healthcare system, how we pay for healthcare, how we organize healthcare. So when I went to medical school, I combined it with a degree in public policy and understanding more about some of those broader forces in healthcare. And I've carried that through in my career. I finished medical school and completed a residency in internal medicine. But after my residency, I did a fellowship in general internal medicine where I learned some of the research skills that I've carried forward in my career, how to study, for example, in healthcare economics, or how to conduct surveys of patients and doctors to understand how they're making decisions together, how to work with large healthcare databases, for example, insurance claims in the Medicare program or the Medicaid program or private insurance data, and how to work with statisticians and economists and social scientists who study how healthcare is delivered, and bringing my clinical knowledge as a physician together with some of the social science skills and economic and statistical and analytic skills that those colleagues have to really think together both what's happening in the individual interactions that doctors and patients have with understanding some of those larger societal forces at work, when we look at how healthcare is delivered more broadly in the way that our system is structured.
So you really speak on, this aspect of you completing that fellowship in general internal medicine, and integrating both those sort of social science kind of knowledge with the more clinical knowledge that you have. But considering that you are an internist and you've, spent much of your career caring for patients, while also, leading large scale health policy initiatives, how has just continuing to practice medicine shaped the kinds of questions you choose to study in the policy field?
Yeah. So after I completed my clinical training, and for my career, I've practiced as a primary care physician. So as a general internist, I take care of adults of all ages, really from older teenagers, adolescents, up through adults through the end of life. And so, as a primary care physician, I take care of people with a wide range of healthcare problems, delivering preventive services as well as taking care of people with chronic conditions, heart disease, diabetes, kidney disease, chronic lung disease, mental health problems. So I also throughout my career worked in academic medicine. So working with residents and medical students and fellows in internal medicine. And so I, have had that opportunity to see a wide range of physical and mental health problems that people are living with. And that experience has really shaped the kind of research questions I'm asking. Why do people present to their physicians or to hospitals and clinics at different stages of illness? Why are they treated differently once they arrive into the healthcare system? Why do they have different healthcare outcomes? And our public health colleagues often talk about the social determinants of health, but in my career, I've often been working with colleagues and studying what we call the social determinants of health care. Why do factors like people's gender or their race or ethnicity or their level of education or income or their immigration status or their language skills or their insurance coverage, why do those social and economic factors influence how they access the healthcare system, how they're treated within the healthcare system, and then how they recover or fail to recover when they have healthcare issues and medical problems? And how do we shape the healthcare that we provide in a way that helps people to achieve the best possible healthcare outcomes? So, that's how I've brought my clinical experience and what I've learned from my work in internal medicine and delivering healthcare together with my research experience, in collaborating in research teams with his colleagues in other research disciplines to try and improve the healthcare that we're delivering here in the U.S. And as my career has progressed, also working with colleagues studying healthcare in other countries as well.
I think that's really interesting how you specifically focus on the social determinants of healthcare access, because we know that healthcare access itself is a social determinant of health. But of course, each determinant has its own determinants going in. And sort of on that point of healthcare access and socially determining it, we know that a large segment of Americans rely on healthcare access through programs like Medicaid, Medicare, et cetera, CHIP. And you helped lead that long-term evaluation of Michigan's, Healthy Michigan plan, which allowed Medicaid to be expanded in our state. For listeners who might not be familiar with that work, could you briefly just walk us through what your team set out to study and what findings really stood out to you?
So the Medicaid expansion was part of the Affordable Care Act back in 2010. President Obama signed the Affordable Care Act that had been passed by Congress back in March of 2010. And that expanded health insurance coverage in a number of ways, one of which was the expansion of Medicaid for adults between the ages of 19 and 64 who had low incomes. Medicaid is a partnership between the federal government and state governments, and that's a program that dates back to 1965. Actually, was originally enacted when Lyndon Johnson was president back in the mid 1960s. And it had been a program that was varied quite a bit in states across the country. Each state was able to set very different levels of income that the individuals were eligible for Medicaid. It often covered people with different levels of disability. It covers many older adults who need nursing home care. And then lots of children are covered under the Medicaid program as well. But for working age adults, it was a very program that was very uneven across states across the country. And what the Affordable Care Act did was set a more even income standard. Basically, starting in 2014, the Affordable Care Act said if you were an adult with incomes up to 138% of the federal poverty level, which at that time was about $16,000 a year, you would be eligible for Medicaid in any state across the country. Now, what the Supreme Court said in 2012 was that Congress could not force all 50 states to adopt that same standard, that they had to allow states individually to decide whether they wanted to accept that standard. And the federal government, as part of the Affordable Care Act, was going to pay the full cost of the Medicaid expansion for the first 3 years, and then about 90% of that cost for all years after that. And so Michigan decided, as did now 40 other states across the country in the District of Columbia, that they would accept that federal funding and expand Medicaid. So starting in 2014, Michigan expanded Medicaid in what's called the Healthy Michigan Plan, like you referenced in your question to me. And but when Michigan expanded Medicaid, it required a bipartisan agreement. At the time, Michigan was one of the few Republican-led states. Here in Michigan, we had a Republican governor, a Republican legislature, and in the decision to expand Medicaid, they decided to add some Republican-favored provisions, such as health savings accounts and financial incentives for healthy behaviors, a strong focus on primary care, and so because of those Republican features, it required a waiver from the federal government, and that waiver required an independent evaluation. So our state health department came to a team of us here at the University of Michigan and asked us to lead an independent evaluation of the Healthy Michigan Plan. And so over the decade from 2014 to 2024, we've been evaluating that expansion of Medicaid. And what we found basically is that for about 700,000 adults who enrolled in the Medicaid expansion, which represents about 7% of the 10 million population of Michigan, that access is improved, that the enrollees in the Healthy Michigan Plan tell us that their physical health, their mental health, their dental health have all improved over the time that they've enrolled in this plan, that many more of them are getting primary care and that they're using primary care and less frequently using emergency departments for their medical care, which is generally a good thing because people generally have their health needs met more effectively if they're going for care in a primary care office rather. Emergency departments are important when people need them for true emergencies, but they're not the best place to get your preventive care or your chronic disease management, for example, for diabetes or high blood pressure. So, those are some of our key findings. We've also found that people's employment opportunities have improved, and that's important because for both Democrats and Republicans, supporting Medicaid expansion, that's been an important goal. So, those are some of the key findings. We've published, several dozen peer-reviewed articles and a number of reports to the state and federal government. And it's been a real team effort. We've had about 15 faculty and a similar number of staff from different schools, the medical school, School of Public Health, the business school, working together, School of Social Work, and the Ford School of Public Policy on this evaluation, and partnering with our colleagues at the state government and federal government to generate this evidence. And it's helped other states decide whether they wanted to expand Medicaid as well over the past decade.
You covered a lot of the ways that, the Medicaid expansion positively improved outcomes just beyond people's physical health, also just in terms of the labor that they were able to complete. And I think this really challenged a lot of people's preconceived notions about Medicaid expansion, about the Affordable Care Act itself. Back in 2010, 2008, 2009, 2010, there was a lot of, I guess you could say there was a battle to get the ACA passed on the federal level. And there were a lot of these questions brought up. But you were someone who really had that unique experience of, evaluating the impact of Medicaid expansion, as it was unfolding in Michigan. So, looking back now, what surprised you about that, the gap between how policymakers imagined the expansion would look like and how it impact the population, versus, how patients have actually experienced it since?
Yeah, I think, one area that we could have expected, but I think it was somewhat surprising is just how important Medicaid is to improve people's employment prospects. Oftentimes we think about Medicaid, maybe people are using it instead of working, but what we learned is how important it is to keep people working. That most people on Medicaid actually are working. Well over half are working full-time or part-time. And when they have their Medicaid coverage, they tell us how important it is to help them keep working. Many adults with low incomes need their Medicaid coverage in order to stay healthy enough to keep working. Oftentimes they work in jobs that either don't offer health insurance or
Hmm.
the health insurance is too expensive. They're working minimum wage jobs or part-time jobs for which it's very difficult for them to afford the health insurance, even if it is offered. Or they're seasonal workers. They may work jobs that are only available to them, for example, in the summer months. Um, so, so it's very difficult for them to afford health insurance, given the rising cost of health insurance. And so, Medicaid really fills a crucial gap. And, for example, if they have diabetes or high blood pressure or asthma or depression, where we know, medications and good primary care make such a difference to keep them healthy, getting that medical care through the Medicaid program keeps them healthy and allows them to keep working, and contributing both to their families and to their local economies. So, that was, I think, somewhat of a surprise just how important it is to help. And we saw that in our data that it helped people to
Yes.
stay working, sometimes to get better paying jobs because they were able to maintain their health. Another surprise was just how important the dental coverage is to people within Medicaid. That was a feature. States have an option whether to offer dental coverage through their Medicaid program and their Medicaid expansion. And many of the people that we surveyed and interviewed had not had dental coverage for 5, 10, or 15 years before they enrolled in the Healthy Michigan Plan. And that dental coverage was very important to their overall physical health and oral health. Uh, and that was also important to their mental health and their ability to work. People their quality of life is much better when they're getting good dental care, not just to help them, for example, with chronic pain that they may have from, dental problems, but it also helps their overall sense of well-being. And,
Sure.
if their physical appearance is better because they're having their dental problems taken care of, they feel more confident, for example, when they go out for job interviews, uh, and they're able sometimes to get better paying jobs because of that. So we heard those stories, and we found it was important, for example, when talking to policymakers and political leaders, to share. That was another, I think, important finding, not just to collect good quantitative data, but to collect some of the stories of the Medicaid enrollees. And, that's very important to combine good quantitative data with good qualitative information and the narratives and the stories of the people affected by programs like Medicaid expansion. Whether we were talking to reporters or political leaders or community leaders, that combination of good quantitative data and good stories, the stories of the people affected by the programs or the people delivering the health care to new Medicaid enrollees are important to share.
Mhm. Those personal anecdotes definitely play a role at the levers of power. Just they're what's often cited, and they're often what I feel resonate the most with a lot of policymakers. Which of course, data is important, and people should be looking at data. But it's great that you guys were able to both capture quantitative and qualitative pieces in that work. And I heard you talking about work requirement, sort of the impact on labor. So in a bit, we'll get to work requirements because I think that's a very interesting conversation for our current moment. But before we get there, I want to talk about another finding in your research, just more broadly, which is, that insurance coverage alone has not erased, the sort of disparities that we see in health outcomes, especially here in the United States compared to other peer nations. So what do you think this aspect of your research really revealed about the deeper forces shaping healthcare in America, and health outcomes generally?
Well, that brings us back to the larger social determinants of health that people need good access to medical care, but they also need good education. They need employment opportunities. Some of the structural forces that affect people's health. We know that where people live can affect their health as much or more than genetic factors that often are important. We want to understand biologic forces, certainly, but social forces often and environmental factors can be as important as some of those biologic factors in determining people's health outcomes. So and that's why, we have to think about, uh, for example, early childhood opportunities, making sure that children have, good nutrition, opportunities for early childhood education that are as strong as possible, that families are supported, that employment, opportunities are there for young adults and and middle-aged and older adults as well. Those are all critically important, and that and that mental health is supported. These are critically important, that it's not just enough to give people insurance to deal with problems after they've developed. Ideally, we want to have a focus on prevention and a community orientation that it's not just a matter of treating people as individuals, but thinking about healthy communities and public health approach to maintaining health in the larger society, so that we're thinking about things from an upstream sense of trying to prevent problems before they develop, rather than just addressing them with insurance and access to good medical care. Obviously, we want people to get good treatment after they're developing health problems, but the more we can, think about sort of what are the drivers of health issues and illness before they develop, that will pay big dividends. And so that it's a lot of the concern we have about vaccine preventable illnesses right now is a good example. Obviously, we want people to have the best possible information. We believe in people to have the freedom of choice when it comes to medical information and making personal decisions. But we also want to make sure that people have accurate information, and the children are protected. Particularly children who may have medical problems that make them particularly vulnerable to vaccine preventable illnesses. So. That's a good example where a public health approach, remains critically important.
But why do you think, relative to our peer nations, other OECD countries, we spend so much more per capita on healthcare, yet our outcomes continue to be, while the gap has closed a little bit, but they still continue to be worse?
Well, there are a few reasons for that. One is that we've created a healthcare system where we pay more for a lot of the healthcare services that we offer. We pay more for most of the pharmaceutical drugs that we provide and biologic therapies. We pay more for most of the hospital services and physician services that we provide. And that's just a legacy of the past 50 or 60 years. That it wasn't always that way, but it's largely, in the last 50 to 75 years, that's how our healthcare system has developed. And it's, in part because, we don't have a single payer healthcare system like most other countries that heavily regulate the prices of healthcare that they pay through the government. And then, partly it's because, we have, a lot more income inequality. And so, I think, and fewer social services for lower income people in this country. So, and that, I think, creates more poverty-related illnesses in the U.S. Than in other high-income countries. And for a long time, I think we also had more smoking-related illnesses. We made a lot of progress on that. In fact, now, that's actually a kind of, a public health. I think a lot of public health progress has been made in reducing smoking rates dramatically in this country in the last 50 years. But at the same time, we've developed a lot more obesity-related illnesses, and we're seeing the effects of that. So I think, those are, a few of the the effects of the high prices we pay, that poverty-related illnesses that we experience in this country more so than other countries, and then more recently, effects of the rising obesity rates, and in the last 15 years or so, the opioid epidemic, have all kind of combined to cause a lot of the kind of worsened health outcomes that we see in this country relative to other high-income countries.
I'm going to pivot us back to what we were talking about earlier about, labor in particular. In your work evaluating the Healthy Michigan Plan, you really showed that many Medicaid enrollees were already working, or they were in school, caregiving, some were even doing like volunteer work. But there's a sort of renewed conversation now about Medicaid work requirements. What do you think it is that policymakers continue to misunderstand about the realities of, Medicaid populations, or, people on Medicaid generally?
Well, some of it's just a fundamental disagreement about, how long people should rely on Medicaid. I think many
Mhm.
Republican lawmakers believe that Medicaid should be a more short-term solution for people, and would like them, to transition to employer-sponsored insurance. But I think in part that's, kind of a misplaced um, understanding that that people can get jobs in which employer-sponsored insurance is affordable. Certainly some younger Medicaid enrollees early in their careers will end up in jobs where they can afford insurance, but many kind of middle-aged and older adults on Medicaid just are do not have the employment prospects where they're likely to end up in jobs where they have health insurance that they can afford. They're motivated workers. They're just not, they're in lower wage jobs, or where they won't afford insurance, or they have chronic health problems, at age 55 or 60, where they're just not going to be able to work sufficient hours to afford health insurance on their own, uh, even though they probably can work, 15, 20, 25 hours a week. It's just not enough to afford health insurance on their own. But, they can work a reasonable amount and earn some income if they can keep their Medicaid to help them, afford their medications for high blood pressure or diabetes or whatever other health conditions they have. So it's, and that's where, good data can help. But I think also, sharing the personal stories of people affected in, with those chronic health problems, hopefully can make a difference. The other area where we're, seeing Medicaid make a big difference is helping to support rural hospitals. And, certainly in some of the more conservative states that have chosen to expand Medicaid, that has swayed a number of Republican lawmakers. And it'll be interesting to see, as Medicaid work requirements are implemented, is that going to threaten some of the rural hospitals if many people start to lose their Medicaid coverage? How that affects rural communities, with Republican legislators. Because, in states that did not expand Medicaid, we've seen a number of rural hospitals close, and those are really anchors in their communities, providing a lot of vital services.
I hear you communicating a lot of these different aspects about what made Medicaid expansion so impactful across different states, different environments. And, this is largely in part due to your work in academic medicine. And you, of course, were the founding editor-in-chief of JAMA Health Forum. And for those of you who don't know what that is, it was the JAMA Open Networks journal focused on health policy. Correct me if I stated that incorrectly. But one challenge in academic medicine really has been, how can we translate research into policy change? From your experience, what have you learned about how researchers can more effectively communicate to policymakers or to the public, these changes and what the research is showing?
It's a great question. Here at the University of Michigan, I lead the Institute for Healthcare Policy and Innovation, and that's something we encourage our faculty to really develop the skills to communicate their work more effectively, to think of their research as a starting point, and their academic publications not as a starting point, not an end point. That
Mhm.
it's really important to try to translate the work that we are doing as academic researchers, not just to our peers, to other researchers at universities and academic medical centers, but to folks in the media, in government, in community organizations, in the private sector, to the general public. And we can do that by trying to speak in ways that people can understand, not just in sort of the way we would write for an academic journal, but in the way that people talk in everyday terms. And obviously, there sometimes, these are sort of complicated sort of research methods, but it's important to try to translate that into language that people would use in everyday conversation, and to use examples that people experience in everyday life. And we're talking in the kind of research that I and colleagues do. We're talking about healthcare, we're talking about public health, we're talking about everyday health conditions that people experience in their lives. So it's something that is we can readily do if we put our minds to it, and uh, you know, and and uh, and that makes it more relatable, and it makes it more actionable for example, for policymakers if we can do that well. And I think the other thing is a big challenge is not just to describe the problems that we're seeing in the healthcare system or in public health, but to be working towards understanding what potential solutions are and evaluating those solutions, and providing options. It's a fine line. We're not advocates. We can have our personal opinions,
Sure,
as
yeah.
citizens, as voters. But our role as researchers is to ask tough questions and try to come up with the best evidence for, what works and what doesn't work, whether it's in terms of, individual healthcare options or sort of policy solutions in terms of how the healthcare system is working, or in terms of community health or public health solutions. So, uh, and then, going back to an earlier point in our conversation, bringing together sort of data with stories, often what we call mixed methods, bringing quantitative data together with qualitative stories or narratives, by the people experiencing the health problems or the solutions. That's often kind of the most effective way to communicate our research. What are the stories behind the numbers that kind of really bring the data to light? So, those are some of the ways I think we do our best when we're kind of communicating the research to the broader community.
I really like that view of, qualitative data or qualitative findings because oftentimes, they're used to inform research questions, but here's another way they can be used, sort of to inform the public, the different segments that make up our population. I finally like to always ask our guests for some book recommendations, media recommendations. It could be related to your work or it doesn't need to be. What are some books, shows, media that you'd recommend to our audience?
Well, I have three in mind that I would share, and maybe kind of a brief explanation for each. The first would be, one that you referenced. It's the journal JAMA Health Forum. I served as the founding editor. We launched it back in 2020, and I served as the editor in chief for the first 5 years. And as you mentioned, it's the health policy journal of the JAMA network, and it's an open access journal. So it's available to readers anywhere in the world for free. It does not require a subscription. Its goal is to publish cutting edge health policy research and commentaries, we try to publish research and commentaries that is accessible to a wide range of readers, both physicians and other health professionals and academics, but also folks in the general public and students at all levels. So, that's one that I would recommend. And there's also a podcast that goes with it. So, that would be my first recommendation for people interested in health policy, and both in the U.S. and as well as globally. The second, in terms of a media recommendation, I guess would be the streaming show, The Pit, which captures, sort of what's happening in emergency departments, and while most of it's a lot of tough clinical problems that land in emergency departments, they've actually captured a lot of health policy challenges. For example, what happens to people when they have no insurance or inadequate insurance and they land in an emergency department, or what happens to people with tenuous immigration status who need health care, or people with mental health crises, or people who need end-of-life care that may not be readily available. So a lot of difficult health policy issues in an emergency department that come to a head, let's say, when people are having health crises, would be kind of a media recommendation I'd have. And then a book recommendation I'd have is actually one that was a book written about a close friend of mine, Dr. Paul Farmer. It's the book Mountains Beyond Mountains, written by Tracy Kidder, an acclaimed author who unfortunately passed away in the past year. And my good friend Paul passed away a few years ago, but Paul and I were friends back in college at Duke as undergrads, and went to medical school together at Harvard. And Paul just had a tremendous career. And I'd recommend that for some of your listeners who are students now, undergrads or health professional students, because Paul just had such a passion for his work. And that began for him early in life, and his passion carried him forward through such an amazing career. And and I think that passion is so inspiring, and the story of his life's work told in the book Mountains Beyond Mountains, I think, has been so inspiring to so many people, many of whom have themselves had impactful careers in global health. But I think it's an inspiring life story for people in many different careers. And so that would be my recommendation for a great book, a book of inspiration.
I have to second all three of those phenomenal recommendations, but especially JAMA Health Forum. You're the one who told me about it. And since you did tell me about it, the written articles, along with the podcast, have just been incredibly helpful for me, especially when, learning about those areas that I don't have much understanding of, or I don't want to say expertise, but, a high level understanding of. So, you know, thank you so much for those recommendations. Thank you so much for joining us, Dr. Ayanian. I think this was an incredible conversation, and take care.
I appreciate the invitation. Thank you, Neil.
Thanks for listening to Voices from the Field, the NAMA podcast. If you enjoyed this episode, please make sure to follow us on Instagram, Spotify, Apple Podcasts, and YouTube to stay updated on our upcoming episodes. We'll catch you next time on Voices from the Field.